Good afternoon, everyone. First of all, I would like to thank Professor Marzialoubi for an invitation. I'm very honored to be able to participate in your Congress, but I'm sorry to do it only from this recording, but I am there with all my heart and my toes. I will start this lecture with the definition of the future. The future is for a system a set of possible configurations that do not exist. In the timeline, the future comes after the present and the past. It's from Wikipedia. But if the later definition was simple, what about phlebology? What about the one of this definition? Here, Wikipedia disappointed me. I have more precise sources like all of you. Here is what we can say in synthesis. Phlebology is the study of the anatomy, physiology, and diseases, treatments of the veins. The complete and clinical signs of chronic venous disorder are related to disturbance of the macro and microcirculation. Venous disorders can be acute or chronic. Why this discipline? We need to go back in time to better understand our future. When the human species began to walk in an erect position, this had an influence of venous disease of the lower limbs, leading to the development of varicose veins, among other things. It was therefore necessary to find solution of this began, as we'll see, very early in the history of humanity. And very quickly, men knew how to show great intelligence, but this certainly shows us to what extent the venous disease already affected a large part of the population. During the ancient Egyptian period, varicose vein surgery was not performed, most vein respected, as shown by the Heber papyrus. Hippocrates, the father of medicine, recognized a correlation between varicose vein and ulceration. Then from antiquity, varicose vein surgery appeared with more and more detailed writings. The 19th century saw few changes with, for example, in the central image, an excision of the great saphenous vein, the procedure still being mutilating. It was in the 20th century that things evolved with the appearance of the stripper. Phlebectomy was first described by Aurelius Cornelius and was reinvented a little over 40 years ago by Robert Muller. Robert Linton was the first to describe the operation of subfacial ligation. Coquet describes the extrafacial ligation of perforating vein. And during the 80s, the technique of subfacial endoscopic perforator surgery was developed. It should be noted that since antiquity, we see different needles and syringes appearing. This not ceased to evolve until today. From the 80s, ultrasound is more and more used with two essential contributions in phlebology, which are still relevant today. At the same time, even if the first forms of sclerosing forms was described at the end of the 30s, the 90s years allowed an evolution and standardization of practices. The two detergent sclerosing agents for foaming are polydocanone and sodium tetradecyl sulfate in Europe. In the 90s, there was a large development of techniques to standardize foam manufacturing. Ultrasound-guided sclerotherapy was the first technique to oppose surgery, the gold standard at the time for the treatment of varicose veins. Today, we have two main types of treatment for varicose veins. First of all, the techniques known as thermal tumescent techniques. There are many devices whose objectives remain the same: destroy the vein by providing caloric energy. The more widespread, as you know, and widely used treatment are radiofrequency and laser treatments. The laser use is electromagnetic waves. The radiofrequency is a spectrum of radio waves, and the procedure remains the same. In 2001, Navarro published a study launching the era of laser used in phlebology. For the radiofrequency, several devices were used from 1998. Two other less widespread techniques are also used: microwaves techniques and steam. Non-thermal techniques that do not require tumescence are widespread used, like sclerotherapy, that remains the first known techniques of this category. I'm not going back on it. Mechanochemical endovenous ablation was introduced in 2010 by Chloriven device. The aim is to combine mechanical abrasion of the vein wall and simultaneous injection of sclerosant. Cyanoacrylate glue is more recent for the treatment of varicose veins. The working principle of the glue is quick polymerization upon contact with blood and high viscosity. HIFU, high intensity focused ultrasound, are used in some centers. Finally, in spite of all the research and development put in place by many companies, it is sclerotherapy that resists best at the moment, even if it is not the best technique for saphenous vein. It remains irreplaceable for certain types of varicose veins, particularly recurrent varicose veins and C1 varicose veins. The surface laser, not efficient enough and not versatile. Sclerotherapy in practice is the whole terrain techniques. For the future, there are, in my advice, two axes of reflection. First of all, technology with the notch methods, but often expensive, not always reimbursed, difficulty in supplanting thermal treatment, but needed future development, and the techniques to treat the smallest varicose vein needed to develop with mini fiber laser, why not, hybrid technique or other device improvement. And the strategy. Strategy is very important, perhaps with new treatment criteria, occlusion or quality of life. What are the criteria for the choice of treatment, the cost, reimbursement, best technique, what to treat, what chronology, for example, concomitant and deferred treatment for tributaries, what for recurrent varicose vein disease, sclerotherapy, but there is why not other alternative to come, like glue, for example, foam sclerotherapy for spider vein, but never forget that venous disease is by definition chronic. This development, big development, allows for better treatment and to treat more fragile patients. So things are evolving. But let's talk in a modern way, maybe not about futuristic things, because they have always existed. But today, with the advances we have known in phlebology, we must systematically integrate some patients in our consultation. For example, here, we can speak about children. Varicose vein in children with as lesser incident than in adults, but it's a proven reality. It is largely underdiagnosed, although it could be managed, and at least by medical means and by raising patients' awareness from an early age. As you can see on the English guidelines, it is clearly indicated, as in most guidelines, that the subject of children is not covered. Why not? Then it is extremely important to take into account, again, in this recommendation, that is not advisable to wait until the end of all the pregnancies of a woman to treat a patient varicose vein, which is unfortunately still too often the case and is a source of deterioration of the quality of life of many women. Although this patient is elderly, he has an ulcer with a very poor quality of life. It has been clearly demonstrated, for example, by the Everest study, that the management of his varicose veins will allow his ulcer to heal more quickly and also reduce its recurrence. So now we can treat this patient, even with his 92 years old. Our role in vascular medicine and phlebology goes far beyond that. It is inconceivable today in a consultation not to ask a patient if she does not suffer from a painful abdominal symptoms or dyspareunia or pain during menstruation, for example. Even if it remains surprising, as some patients report, as this type of question is often asked, we realize the service we provide because we are often the only ones to ask it, or very often it is a question of patients who arrive at our consultation after years of diagnostic wandering. Phlebology concerns one individual out of two, and yet, in Europe, phlebology do not have the status of specialty. Phlebologists are general practitioners, vascular surgeon, vascular physician, dermatologist, etc. Taking into account the programs of training of this specialty, there is still no unification of the specialization programs in Europe that makes potential differences in the training in phlebology between the countries. In France, vascular medicine is a real specialty since 2015. However, the delay accumulating during so many years with the total absence of teaching in the classical university course in phlebology is that today the latter still has difficulty to impose itself, despite that with all the good wills that we all have around us, we see the course being structured. In France, phlebology was taught thanks to the will of doctors and surgeons several decades ago who had set up a university degree in phlebology, an optional degree that was offered to each doctor or surgeon who wanted to learn phlebology. It is thanks to this that one could be trained in France. I am a member of the generation as Generation Y, or the Millennial Generation. I was elected president of the oldest learned society in the world, dealing with the discipline that affects about 1 in 2 people of the planet. This took place in a context of profound academic change in France, where vascular medicine has become a specialty in its own right. As I was saying, which I hope you all will find to be the case. But this was also done in a climate of intense social mutation that we all know, and as much as in Italy, you have several societies of phlebology, as much as in France, we have only one, and well, I can assure you that it is not the number that counts. I am not talking about COVID, which has changed our relationship with each other. All this to end on a more philosophical note. These two pictures have nothing to do with each other in appearance, but they are basically identical and reveal a modern concept of extreme simplification of complexity. The complexity that we use every day, let's never forget it. But these tools often make us forget who we are and our values as caregivers, but also those that we have trust the transmission of our knowledge. And this is the future of phlebology. Let's maintain the values of respect. Life is too short, and I remind you it ends badly for everyone. Let's leave our egos aside. The human being is fantastic. Just look around you to see it. How lucky we are. Phlebology is 1 in 2. We are not ready to be unemployed. So I, the little millennial, will have a hard time understanding my successor of Generation Z, and my predecessors may never understand me. But we must not regret anything. We must know how to move on, to pass on when necessary, and never want to leave too big a mark on history. The generations that are coming up have understood that. I thank you for this. To finish, and for me, the future of phlebology is young, yes, but it must always remain connected to its roots, whatever the generation concerned. I look forward to seeing you in Paris in November in our next Congress. Thank you very much for your attention.